So welcome to this presentation from me, Dr Malik, on the Edwards S3 Ultra Resilia valve. That's quite a mouthful, but it's the latest generation of the Edwards TAVI valve. This is the first case in the NHS of this new technology. I work at the Hammersmith Hospital where this case was done, and also at One Wellbed Heart Health. You can check out my own website at London Cardiovascular Clinic. So Dr Foote is the mother-in-law of a colleague. She is a retired doctor herself. She's the wife of a retired cardiologist. She's been referred by one of my cardiology colleagues, so she is a well-connected lady. But on top of that, she's 82 and looking very good on it. She's a mother and she's a grandmother. She, of course, has severe symptomatic aortic valve stenosis, and in addition has paroxysmal atrial fibrillation and irregular heartbeat. Previously normal coronary arteries, hopefully they'll be that way as well. And we check high cholesterol, but also some bony problems with arthritis, spinal stenosis, carpal tunnel syndrome. So we have a fairly mobile lady who we want to make even more mobile because her valve is not very mobile. You can see there that aortic valve is pretty narrow, and the numbers all say it is narrow, and that's a reason for her increasing breathlessness and reduction in exercise tolerance. This is a CT analysis done in a fancy system called 3Mensio, which allows to plan the procedure carefully and effectively and choose the right size technology. So two choices to make. Should this be open heart surgery, AVR, or TAVI, a transcatheter aortic valve? Well, she's over 80, she's suitable for a TAVI, so that's a fairly easy decision in 2024. This should be a TAVI. The next decision is what technology of TAVI. Is it a self-expanding valve or a balloon expanding valve? She's got quite a small annulus of 20 millimeters. That's the diameter of the valve we can get in. And there is a recent trial called SMART that suggests the gradients across that would be lower if we put a self-expanding valve like a Medtronic or Abbott rather than a balloon expanding valve like an Edwards valve. However, I'm going to use an Edwards valve. Well, it's an iterative technology. So the first valve was 2007, we're now in 2024, and I'll take you through why this may be better. The most important thing, it's now had a preparation on it called Resilia, which tries to reduce the risk of calcium occurring in the future. We'll find out in the next 10 years if that's definitely going to be working out. But in addition, it's got a tall skirt on the outside to reduce the risk of leak around the valve, and they've actually made the posts of the valve, so these things, narrow on the small valve to try and squeeze more area out of the middle. It's made of cow pericardium. Some companies use pig, some use cow. This is a cow pericardium, and the skirt on the outside is tall to reduce that risk of leak. So what is this technology? Well, it's prepared. Remember, this is not cow pericardium taken out of the cow and put straight into the patient. It's prepared in quite a hefty way and then hand sewn to create the leaflets. The aldehyde technology used to try and leach out the cow cells and leave only the collagen behind needs to be capped off so that you can reduce the risk of calcium occurring in the future. So we're going to do an echocardiogram, ultrasound guided access of the legs to make sure we have safe access into the blood vessels that we need, an angiogram of the heart, an angiogram of the aorta. We're going to cross the valve, sometimes difficult if it's very narrowed. We're going to assess the pressure before and after, so here's the before. A stiff wire called the safari is put into the ventricle, and we prepare the valve carefully. It needs to be mounted onto a balloon. We insert the valve, take back the pusher technology that allows us to push it into the right position of the heart, deploy the valve, hopefully in the correct position, remove the valve, do an echocardiogram to check everything is correct, there are no complications, check with hemodynamics that again the pressure gradient across the valve is now close to zero, and remove the sheath, check the angiogram, and get Dr Foote to the ward. So let's see the access. So we'll watch this video. So we set up in the cath lab. Here's the ultrasound. We take a venous access. So I'm inserting an anesthetic. You can see the needle moving towards that black horizontal line, which is the vein in the first instance. Once we've infiltrated anesthetic, to rotate so that we can see the needle coming close to the top of the vessel. And once the anesthetic is in, then I change over to a needle on a syringe and get closer and closer to the vein, and under pretty much direct vision because of the ultrasound, pop into the vein. The vein is to the left of the screen, the other black circle is on the slightly more on the right of the screen. That's the artery. We don't touch that yet. You can see blood coming into the needle. That's from the vein. A little wire goes into the vein. It's called a Seldinger technique, and I leave that wire in position and then get access to the artery in a very similar way. So again, anesthetic is being put in. The horizontal black wide line at the bottom of the right hand picture is the artery, and once I'm getting closer to the artery, then I rotate over the probe so it becomes a black circle. It's the short axis view rather than long axis view. Hear me rotating the probe onto the short axis view, and once I've got that infiltrated, I'll get my Kimmel needle again to actually poke the front of the artery so that we can safely get access to the left femoral artery. And once we've got access to the left femoral artery, then we have our sheaths going into the plastic pipes that go in to allow us to put our equipment in safely without damaging the rest of the vessel. And you can see on the right hand picture, I'm nudging the front of the vessel, and eventually you'll see a little splurge of blood on the left hand panel as I get into the vessel itself. And so there's blood coming out. Pass a wire into that, and now we've got safe access on both blood vessels on the left leg. The venous line we usually give to the anaesthetist. So Dr Foote is awake pretty much completely at the moment. We've anesthetized, and so these little sharp stabs I'm doing don't cause her any discomfort. But at the Hammersmith, we always have an anaesthetist in the room in case Dr Foote became much more uncomfortable. Anaesthetists at the moment has given intravenous paracetamol, but are at the top end in case they're needed if there's a complication or if this procedure becomes uncomfortable. But people who've worked with me will know that actually a lot of the anesthetic that we give is my constant chat almost all the way through the case, because if you know there's going to be a push or a pull or a sharp scratch, then you're much more comfortable. So here's the right leg. This is going to be our main access, and so that jet of color you saw was me just checking that was the artery and not the vein. And again, we're in long axis. I'm putting some anesthetic in, so I've told Dr Foote that the little needle was coming in, and I get my picture sorted out again, and you can see that little dabbing movement I'm doing and is infiltrating anesthetic into the skin. And once I've got that infiltrated, you can see that I'm giving a generous amount. It's 20 mils of anesthetic. It's back with my slightly larger needle, again getting my picture sorted out in the horizontal axis so that I can then gently move towards the artery. And you can see that again in the picture there's a nudging that's going towards the horizontal black line, and once I get close to the horizontal black line, then I will be again doing the same thing, rotating to the short axis view and trying to get to the front of the vessel. A big pipe is going to go into this blood vessel, so this needs to be an accurate puncture. The days of just doing it under an X-ray machine or blindly are definitely gone, and you'll see that I move my needle until it's hitting really the top of the black circle that's in the middle of the picture. And once I'm comfortable that that is where it's going to be, and I'm moving my ultrasound probe around, dabbing with the needle, and here we go. Now I think we can see we're at the top of that black circle. We're going to slowly push forward. Blood's going to come out of the needle, and I'm going to pass a wire into that, and again get safe access. So here's my wire going in again to get safe access. Okay, so we do an angiogram of both legs, and we can see that that's the artery on the left side, and this is the artery on the right side. We already know on CT they're big enough to actually take our procedure. So the puncture points are in the right place, which are above on the femoral head, basically. So let's have a look at the echocardiogram. So this is the pre-TAVI echocardiogram. This is the left ventricle, and this is the aortic valve being pointed out, which is restricted. As we go through, we'll see that we take several pictures of this valve. So those not used to looking at echo, take my word for it that this valve is not looking normal. We also do short axis views where the ventricle is like a circle and it's crunching down nicely. And you'll see also we do 4-chamber view. All 4 chambers of the heart are seen in one place. That's the left ventricle being pointed out, so that we can check that the heart is fairly happy at the moment. I must say not every hospital does this, but my feeling is very strongly that we should look in detail at the valve before and after in any way we can in the lab. We're assessing the gradients below the valve and above the valve here to make sure that we know that this is a severely narrowed valve. And so then we do a review of the coronary angiogram. You can see my hands on the table, and here's the left coronary artery being shown with no disease at all, which is great news. and then we move to the right coronary artery, which is a C-shaped artery, again with very little disease in it. So that is actually very, very good news. But we're now going to dilate the right femoral artery so we can get the sheath in that we need to deliver the valve. And so on table, it's put into a soft case, put into a squasher basically, because this now needs to be squashed into position on the balloon. So it's been positioned, there's the balloon, and the balloon is going to be put into the squasher. It's called a crimper, in fact, that's a formal name, and Paula from Edwards is squashing this down into position. Of course, it has to be the correct way around. An upside down valve would be terrible. The skirt of the valve has to go towards the left ventricle, so the valve is not upside down, but Paula's good at assessing that sort of thing, and we always double check. So that white skirt you can see towards the tip of the balloon is the skirt, so this is yet again correctly positioned. So we've done an aortogram, and I'll just illustrate that we need to be careful. So there's an aortogram there, which I do just with 2 catheters, and a second aortogram, which in my mind looks better aligned, because the cusp in the middle, there are 3 cusps to this valve, is in a better position. So we've got our marker perfectly sorted out. There's a pigtail catheter in position, and we've got the 3 cusps of the valve fully aligned, and that's the way I tend to put the valve in. So we're going to insert a pigtail catheter into the ventricle. That's going in, and that allows us to take hemodynamics, so we can now take pressure from below the valve, and above that there's a gap between the aortic pressure and the LV pressure, and that gives us the gradient across the valve. Great, so that's the still of that picture, and the grey shaded area shows that there is severe aortic stenosis. The mean gradient is 32 and peak is 34, and hopefully it'll get to close to 0 at the end of the procedure. The sheath has been prepared and put into the body, and now the valve contraption is going in. You can see it's quite a complicated technology, but we're very used to doing it, and the idea is to pull the balloon, which is now being done, into the valve in preparation. To make the thing as slim as possible, the balloon is in advance of where the valve is mounted on the long pipe that goes into the leg. And as we pull that handle back, the balloon goes in, and then we do some more fine tuning of it to actually bring the dots of the balloon completely in, and you'll see that slowly go. That's used with a fine tuning adjustment wheel, which is just rotated, and this is slowly drawing in. And once we have the dots fully aligned, and then we can move to the next stage of the procedure. So that's a dot pretty much aligned, but you can see there's maybe a slight parallax, but we'll sort that out once we get to the next stage, and that the final stage of the dot is just brought into the balloon, just over here. So now we're ready. We've pushed it across into position, across the valve, and then this is the pusher coming backwards. So it's used to actually allow us to get the valve into position, pull that back to the right position, and once that's ready to go, we'll do a final check on the position of the valve. So there's an angiogram being done, and you can see the valve is in a good position. There's a lucent line that I tend to use for a high deployment, and so now we're ready for the valve being deployed. And there is the valve being deployed under rapid pacing. It goes into position. We deflate the balloon, the pressure recovers. Dr Foote's still awake, and we just warn her that the heart's going to go quickly, but because she's lying down flat, it's a fairly rapid deployment, and we don't really have an issue. To show you a schematic, we rapidly pace, and the valve's deployed into position and locks in with the calcium locking things in position. You can see the skirt, which hopefully will reduce any chance of paravalvular leak. So you can see there's no obvious leak. I'm looking at the height really on this, and the height is perfect in my mind, so that's good news. But let's check the hemodynamics again. So we need to be sure that the pressure afterwards is as low as possible. So I zero all the catheters. And now look, there's no gap in between the two. There's 0 gradient. So although the SMART trial will tell you that there are gradients across these small valves, it's hard to believe that any valve would have produced a better result than a 0 gradient. So I'm very happy with that. So I always do these hemodynamics. So once I've done the hemodynamics, I've taken the pigtail catheter back, and you can see before and after. There was a 30 to 40 gradient before, now 0 gradient, which is great news. We're then going to remove the sheath and tie up. The big pipe is coming out. I've pre-sutured with a couple of sutures on the blood vessel, and we pull those tight. So the sheath is coming out. We've got good control of the artery, And again, remember, Dr. Foote's wide awake. There is no problem here. More amount of pressure. We tighten up the prostyle sutures and tie these off. So that sutures the vessel from the inside, and actually on the outside there is no suture material and actually just a band-aid. We always check the large puncture site. Here's an angiogram to say, look, the artery is absolutely fine. So we started at 5 to 9, we finished at 5 to 10. The valve is now in position. This is the echocardiogram afterwards, and so we can now see that the gradients across the valve are significantly reduced. The ECG changed slightly, and so I kept her overnight. And here is Dr. Foote on the ward. This is actually her evening of the procedure, but because of that slight ECG change, I kept her home until the following day, and then she went home, and she's doing very well. So in summary, this is the UK's first Edwards Resilia valve, and in the short term, in the first 24 hours, it's done very well. I'm sure it will also do very well in the long term. It's my thanks to the wonderful team at the Hammersmith Hospital. For Edwards Life Sciences, actually gave me the first NHS Edwards Resilia valve because, of course, it is Dr. Foote. She's a special lady, and I asked nicely. And for Dr. Foote for allowing me to film this case and talk about her, and I'm sure she's going to do very well under follow-up with Dr. Rana, again, one of my colleagues. So thank you very much for joining me. If you want to see more, then you can join me at the London Cardiovascular Clinic on the website, or my YouTube channel, London Cardio Clinic, where I've got lots of videos of me doing procedures and other things.